بسم الله الرحمن الرحيم. المحاضرة الرابعة من chapter Hematology is Hemoglobinopathies. We should know what is normal hemoglobin. Normal hemoglobin is adult hemoglobin or hemoglobin A containing 2 alpha chain, 2 beta chain. Any abnormalities in this protein referred to as hemoglobinopathies. Hemoglobin containing 2 alpha, 2 gamma is hemoglobin F. And if hemoglobin containing 2 alpha 2 delta is hemoglobin A2. Hemoglobin F is the fetal hemoglobin. Hemoglobin A2 is the hemoglobin which increase in case of thalassemia trait or minor or carrier, the same meaning. Depending upon the genetic defect or deletion lies in the transmission of alpha or beta globin chain, thalassemia are classified into alpha and beta thalassemia. If the defect in the alpha gene, alpha thalassemia; if the defect in the beta gene, beta thalassemia. Each of the two main types of thalassemia may occur as heterozygous or minor state, or homozygous, which is the disease can be major and intermediate. Fetal hemoglobin is the main hemoglobin during fetal life at birth, whereas hemoglobin A is the main hemoglobin after birth. A2 hemoglobin is a minor hemoglobin that appears shortly before birth and remain at low level after birth, remain below than 2.5%. Normal hemoglobin pattern is more than 95% hemoglobin A, less than 33.5% hemoglobin A2, and less than 2.5 hemoglobin F. Now we will start with sickle cell disease. The common sickle cell syndrome are homozygous SS disease, and other is hemoglobin SC disease, hemoglobin SB thalassemia, sickle. As a result of single amino acid substitution, valine for the glutamic acid at the B6 position, hemoglobin S molecules interact with each other, forming rigid polymers that give the RBC its characteristic sickle shape, polyhalassumiated sickle cell disease. This sickle cell shape RBC leading to a shortened RBC lifespan and hemolysis. Hemoglobin S cells change from a normal biconcave disc, which is the normal RBC, to a sickle form with resultant decreased deformability in the deoxygenated condition, so results in occlusion of the microvasculature, and the surrounding tissue will undergo infarction, inducing pain and dysfunction. This is the main problem in sickle cell disease. Sickling phenomena is exacerbated by hypoxia, acidosis, extreme temperature, and dehydration. Clinical manifestation of sickle cell disease. Sickle cell disease is presented with crisis. The most common crisis: hand-foot syndrome, vaso-occlusive crisis, acute chest syndrome, aplastic crisis, splenic sequestration crisis. Hyperhemolytic crisis occur in patient who is sickler and at the same time has deficiency of the glucose 6-phosphate dehydrogenase enzyme. CNS disorder and susceptibility to infection. These are the clinical manifestation of sickle cell disease. Acute vaso-occlusive pain or acute vaso-occlusive crisis is the main presentation of sickle cell disease, occur due to occlusion of the small vasculature leading to distal organ ischemia and pain. Treatment is hydration, oral or IV fluid with analgesia. If no response to this, supportive therapy, a blood transfusion is indicated. A plastic crisis due to human parvovirus B19, and any child with sickle cell disease who present with, you know that he is sickler and present with fever and decreased retic should be presumed to have parvovirus infection until proven otherwise. Acute exacerbation of anemia is treated in this case conservatively using red cell transfusion when the patient becomes hemodynamically symptomatic or the patient is symptomatic hemodynamically. Splenic sequestration crisis. In sickle cell disease, the spleen usually is small and getting enlarged till about 4 to 5 years, slightly enlarging, just palpable spleen, but then will be shrinked and called autosplenectomy due to repeated infarction and thrombosis in the spleen. When you suspect splenic sequestration, as you know, sickle cell patient has small spleen, but if all of a sudden he developed shock-like state with excessive enlargement of the spleen, then this is splenic sequestration crisis. Treatment includes maintenance of hemodynamic stability and prophylactic splenectomy performed after acute episode has resolved. It is the only effective strategy for preventing future life-threatening episodes. Hand-foot syndrome or dactylitis. It is often the first manifestation of pain in the infant and young children with sickle cell anemia, occurring in 50% of children by their second year of life. Dactylitis often manifests with symmetric or unilateral swelling of the hand and or feet. Can be confused with osteomyelitis, but dactylitis requires palliation with pain medication only analgesia, whereas osteomyelitis require heavy dose and at least 4 to 6 weeks of IV antibiotics. Acute chest syndrome refers to a life-threatening pulmonary complication of sickle cell disease defined as a new radio density on the chest radiography. يعني ناخذ chest X-ray نشوف new radio density patch in the chest X-ray plus any two of the following: either fever with respiratory distress, with hypoxia, with cough, and or chest pain. Diagnosis of sickle cell disease by a newborn screening program and by diagnosis include thin layer isoelectric focusing and high performance liquid chromatography HPLC. Complete blood picture and hemoglobin phenotype determination is recommended for both parents to confirm the diagnosis. I'm sorry, the net is problematic. Treatment of sickle cell disease blood transfusion is indicated only in pain crisis not responding to supportive therapy, also aplastic crisis, hyperhemolytic crisis, splenic sequestration crisis, for any surgery under GA during pregnancy may require blood transfusion. These are the indication in sickle cell disease. These are the indication for blood transfusion. Then folate supplementation. Any chronic anemia require, any chronic hemolytic anemia require folic acid supplementation. Hydroxyurea, this will increase the hemoglobin F, so will dilute the blood, decreasing the crisis. Hematopoietic stem cell transplantation is the curative therapy. Then, if the patient become blood transfusion dependent, develop hemosiderosis and require a treatment for iron overload. What is the treatment of iron overload? Is iron chelating agent, deferoxamine or deferazirox or deferriprone tablet. Anticipated for this, they should take special attention to the disease-specific guidance and infection prevention, will adhere to penicillin and vaccination, seek immediate medical attention for all febrile illness, and early detection of acute splenic sequestration. Prophylactic penicillin. Children with sickle cell anemia should receive prophylactic oral penicillin until at least 5 years of age. 125 mg twice daily up to 3 years and 250 mg twice daily thereafter. No established guidance exists for penicillin prophylaxis. There are many controversies is to continue for life or to stop up to 5 years. There are many controversies in this case. Immunization is important because they are immune deficient, because their spleen is liable for infection and getting smaller and smaller, which is called autosplenectomy. So require routine childhood immunization is important, and annual administration of influenza vaccine. Even they require immunization against encapsulated organisms, the same as splenectomized patient. Sickle cell trait mean فقط حامل للصفة الوراثية. Sickle cell trait or called minor or carrier. The lifespan is normal here, and serious complications are extremely rare. The complete blood picture within the normal range. Hemoglobin analysis revealing typically hemoglobin A more than 50% and hemoglobin S less than 50%. It protects against malaria. Now we will start with thalassemia syndrome. We said that if the defect in alpha chain, alpha thalassemia, defect in the beta chain, beta thalassemia. Now we'll start with alpha thalassemia. There are 4 alpha genes are present on the 2 number 16 chromosome. If there is single gene deletion, will produce silent carrier state. Of 2 genes will produce alpha thalassemia minor. Deletion of 3 genes will lead to hemoglobin H. Deletion of the 4th gene will lead to hydrox fetalis. Treatment of alpha thalassemia, folate supplementation, splenectomy, intermittent transfusion, chronic transfusion therapy, or bone marrow transplant for survivor of hydrox fetalis only. Now, most common presentation here in our locality in the Al-Athir Hospital Center of Thalassemia is beta thalassemia major, which is called impaired beta chain synthesis, resulting in RBC destruction either in the bone marrow or in the spleen when the cell is released. When describing beta thalassemia gene, we said beta 0 or beta plus. Beta 0 indicates no hemoglobin A, beta plus containing some hemoglobin A. Mode of inheritance is autosomal recessive. You see here the father is carrier and the mother is carrier, so the offspring will be 25% normal, 25% disease, and 50% carrier. These incidents in each pregnancy. In each pregnancy, we notice that 25% will be affected, and 25% or normal, or 50% will be carrier. Clinical manifestation from the face, you notice maxillary hyperplasia, flat nasal bridge, frontal bossing, pathological fracture, marked hepatosplenomegaly, cachexia. Splenomegaly will lead to hypersplenism and abdominal symptom. Treatment is to keep the hemoglobin above 10 grams per deciliter by hypertransfusion program, and this blood transfusion, and there is an increase in the absorption of iron from the intestine, also from the hemolysis of the RBC. These all will lead to hemosiderosis. Each 1 ml of packed RBC containing 1 milligram of iron. This iron will precipitate in the organ, leading to failure of that organ. For example, hypothyroidism, hypogonadotrophic gonadism, growth hormone deficiency, hypoparathyroidism, and diabetes mellitus if it is precipitated in the pancreas. Iron deposition in the heart leads to heart failure and arrhythmia. Heart disease is the leading cause of death in inadequately chelated patient. Investigation by severe anemia. Reticulocyte count is less than 8%. Microcytosis, increased unconjugated serum bilirubin, elevated serum creatine, evidence of bone marrow hyperplasia. Hemoglobin electrophoresis is not definitive, but DNA diagnosis of the beta thalassemia mutation along with parental and family testing. Following the definitive diagnosis, family should undergo detailed counseling. Detailed counseling is a must in all inherited disease. Diagnosis of thalassemia in general can be done for the patient himself by doing the HPLC, or prenatal screening قبل الزواج, or prenatal screening during the pregnancy. We can take sample from the chorionic coli or the amniotic fluid to diagnose if the fetus is affected or not. But in our locality, we have no fatwa for termination of the pregnancy. Treatment of thalassemia by hypertransfusion program, folic acid chelation therapy. You must remember that clinical feature of thalassemia is feature of anemia and hemosiderosis. Well, the treatment of thalassemia also is the treatment of anemia and treating the iron overload. Hydroxyurea is given in case of thalassemia intermedia to increase hemoglobin F. Splenectomy done as a palliative therapy and to decrease blood requirement. But hematopoietic stem cell transplantation is the only curative therapy. Gene therapy is in the supports in the recent future to treat any disease.